Acute pulmonary edema, usually it denotes pulmonary edema due to left ventricular failure. But pulmonary edema may arise from ARDS. You might have heard ARDS, acute respiratory distress syndrome, ARDS. In ARDS, there is also pulmonary edema. Broadly speaking, acute pulmonary edema contain both cardiogenic pulmonary edema due to left ventricular failure and due to ARDS. But we mainly emphasize or focus on acute cardiogenic pulmonary edema today. But we will go through this ARDS also because this condition also causes pulmonary edema. But this pulmonary mechanism of pulmonary edema due to ARDS and acute left ventricular failure is totally different. By definition, pulmonary edema means accumulation of fluid in lung interstitium or alveoli. Do you understand this? Hello?
Yes, sir.
Yes, sir.
Okay. Yes, there is no fluid in the extra fluid in the alveoli and interstitium. When there is collection of fluid in the alveoli or interstitium of the lung or pulmonary interstitium, this condition is called pulmonary edema. This pulmonary edema is a dangerous thing and it may cause severe respiratory failure and patient may die if not addressed immediately. So this is a medical emergency and this is very common. This condition is very common and this pulmonary edema results from two conditions I already mentioned. One is increase in hydrostatic pressure. Hydrostatic pressure means there is increased pressure due to fluid contained in the vasculature. There is left ventricular failure. There will be back pressure, increase in pressure is increased in the left atrium. Left atrium pressure causes increase in pressure in the pulmonary vein and it causes increase in hydrostatic pressure in the pulmonary vein, and this increase in hydrostatic pressure may cause further increase in pressure in the capillaries of the pulmonary circulation, especially in the pulmonary vein side, and water molecule leaks into the interstitium. If severe, and alveoli may be flooded with fluid. This condition is due to increase in hydrostatic pressure, or this is also called pulmonary edema due to left ventricular failure. It is also called cardiogenic pulmonary edema. Same thing, increase in hydrostatic pressure or increased pressure pulmonary edema, same thing. You might find some different terminology in different literature, but you should know this is due to increased hydrostatic pressure. Hydrostatic pressure or increased pressure pulmonary edema, increased hydrostatic pressure, these are all due to cardiogenic pulmonary edema. Heart failure, heart is not pumping properly. There is increase in end diastolic pressure in the left ventricle. This causes increased pressure in the left atrium, and this pressure is backwardly reflected into the pulmonary vein, which causes pressure, increased pressure in the pulmonary vein circulation, and water molecule, when it exceeds oncotic pressure of the vessel, and water molecules leaks into the pulmonary interstitium and alveoli. In normal condition, there is balance between oncotic pressure and hydrostatic pressure in the vasculature. Decrease of oncotic pressure may also cause leakage of fluid into the interstitium. Similarly, increase in hydrostatic pressure, when it exceeds oncotic pressure, water molecule leaks into the interstitium anywhere in the body. This is the mechanism of edema formation: increase hydrostatic pressure or decrease oncotic pressure. In case of left ventricular failure, there is increase in hydrostatic pressure. Usually there is no change in oncotic pressure. When this hydrostatic pressure exceeds oncotic pressure, then water molecule leaks into the interstitium and into the alveoli. This is increased hydrostatic pressure due to left ventricular failure. Okay, another is increase in, I already mentioned, to pulmonary edema. This edema seen in the lung in case of ARDS is also called pulmonary edema, but mechanism is different. This edema is due to increase in barrier conductance. Increase in barrier conductance. This means this is increase in barrier conductance. Conductance means conductivity of the vessel is increased. This is due to in ARDS there is damage to the endothelial cell of the capillary. There is damage in the alveoli, alveolar wall. There is damage to the endothelium. Oh, यहाँ तो हल्ला पो भयो, उता पनि भयो, यता पनि भयो. Okay, increase in barrier conductance means there is damage to the endothelial cell of the capillaries of the in the alveoli, and there is no barrier, and protein and fluid may leak into the alveoli. This is due to increase in barrier conductance. Barrier conductance means there is damage to the endothelial cell of the capillaries, and protein and fluid may leak into the alveoli. This is due to increased conductivity. Barrier is breached, or barrier of the endothelium is breached. There may be damage to the basement membrane as well. When this barrier is breached or damaged, water molecule and along with protein may leak into the interstitium. This is called increase in barrier conductance. This is also called increased permeability pulmonary edema, because damage to the endothelium and basement membrane and water molecule and this protein may leak into the pulmonary, leak into the alveoli. So this is called increase in barrier conductance or increase in permeability. This is also called non-cardiogenic pulmonary edema. Your mechanism is different. In cardiogenic pulmonary edema, there is increased hydrostatic pressure because of failure of the left ventricle. Pressure is backwardly reflected, and pressure is transmitted backward from left ventricle, left atrium, pulmonary vein, and increase in hydrostatic pressure. When this hydrostatic pressure exceeds oncotic pressure, water molecule leaks into the interstitium and the alveoli. And in case of ARDS or non-cardiogenic pulmonary edema, damage is in the endothelium of the capillary or epithelium of the alveoli. Epithelium of the alveoli or endothelium of the capillary may be damaged, and there is no restriction of fluid and serum content into the alveoli, and water molecule along with protein easily shift into the alveoli. This is because of damage to the endothelium of the capillary or damage to the epithelial cell of the alveoli. There may be damage to the pneumocyte, type 1 pneumocyte and type 2 pneumocyte due to different insult we discuss later. And this is called non-cardiogenic pulmonary edema. This is usually the case in ARDS. You remember this. If you are very clear about these two mechanisms of edema formation, then there will be no problem. Other thing can be deduced easily. Okay, let's talk about the non-cardiogenic pulmonary edema shortly. This is also very important. Various illnesses and injury may affect lung directly or indirectly. There are so many cases: trauma, toxin inhalation, or gastric content aspiration, or different types of infection as part of septic shock. There may be damage to the endothelium of the capillary and damage to the epithelium of the alveoli, and this damage causes leakage of fluid and protein into the alveoli. This initiates, there may be infiltration of cells because of At the same time, cells may be leaked into the alveoli, and there are inflammatory cells which may initiate. This damage may be due to toxins or different toxins produced by bacteria, or different toxin produced by this tissue necrosis or tissue damage. These toxins may be cytokines, inflammatory mediators. There are so many things which may attack epithelial cell of the alveoli and endothelial cell of the capillaries, and damage may occur. Sludging of epithelial cell of the alveoli, and damage or denudation of this capillary endothelial cell may breach the barrier conductance, and water molecule leaks into the alveoli. So many causes can lead to this type of pulmonary edema, result in endothelial damage and damage and collection of fluid in the alveoli. And ARDS, this I already mentioned, this is the case of ARDS. And in ARDS, there is neutrophil sequestration in pulmonary capillaries. In capillary, there is accumulation of neutrophils in the capillaries because of different toxins produced by bacteria or necrotic tissue or some conditions. There will be sequestration or accumulation of neutrophil in the endothelium, and these cells start to secrete a number of cytokines and inflammatory mediators, which may attract more and more inflammatory cells, lymphocytes, and they start to perpetuate. They perpetuate the ongoing inflammatory cascade in the capillaries and in the alveoli. Increased capillary permeability will be there because of damage, and protein-rich pulmonary edema with hyaline membrane formation. You might have been taught in pathology, there is hyaline membrane change in the alveoli. Hyaline means mirror-like, homogeneous proteinous substance accumulated in the alveoli gives rise to hyaline membrane formation. This is due to protein and cell debris secondary to damage to the endothelium and damage to the epithelium. It also damages type 2 pneumocytes, which is responsible for secretion of surfactant. Depletion of surfactant leads to collapse of the alveoli. This is dangerous thing. When alveoli collapse, there will be impairment of ventilation and gas exchange. Epithelial is damaged, endothelium is damaged, alveoli go into atelectasis or collapse. Atelectasis means collapse. Go into atelectasis, and there will be impairment of ventilation, impairment of gas exchange. All these conditions may lead to severe, difficult to correct hypoxemia. You remember, ARDS is characterized by severe, difficult to correct hypoxemia or hypoxia. This is because of alveoli, atelectasis of the alveoli, shunting. Because of alveoli collapse, there will be no blood supply. Even if there is blood supply, no aeration over that area, and deoxygenated blood directly enter into the systemic circulation, goes into the unoxygenated or deoxygenated blood directly enter into the pulmonary vein. So this condition leads to severe hypoxia, which is difficult to correct. Usually patient need to be ventilated, intubation and ventilated, and usually require positive pressure ventilation, PEEP. You might have heard positive peak expiratory flow. Even during the expiration, there should be application of some pressure in the ventilator, PEEP. Peak expiratory flow rate during this ventilation. During ventilation, patient require high pressure to open up the atelectatic alveoli. This is what in the case of ARDS. So difficult, very severe hypoxia, difficult to correct. Usually patient require ventilation, intubation and ventilation, and usually patient require PEEP. This is very important. You must remember this. Conditions may be different. Condition leading to ARDS may be different. Maybe inhalation, direct factors may be responsible. For example, aspiration of gastric content Sometimes patient may have severe esophageal reflux, and sometimes may be aspirated into the lung. This acid and protein substance may enter the lung circulation, may enter the lower respiratory tract, and this may damage epithelium and damage the endothelium, and may cause uh, impairment of gas exchange and impairment of oxygenation. Toxic gases and burn injury may also cause toxic gases, and pneumonia, severe pneumonia. Pneumonia itself can cause ARDS, and blunt chest injury and lung contusion may be the cause. Drowning when patient is swimming, and sometimes he may be not very adept in swimming, and patient may be drowned, and in such condition it may also cause ARDS. Blood burn may be there, blood burn conditions or insults, blood burn insults may be there, which may indirectly damage the lung. Pneumonia, blunt chest injury, near drowning, toxic gas or injuries, toxic gas inhalation, gastric content inhalation, these may directly damage the lung. But indirect evidence, there may be insult somewhere in the body, somewhere not in the lung, somewhere outside the lung, and these condition may also damage the lung through inflammatory process. There may be toxins, there may be endotoxin, there may be exotoxin, there may be different enzymes released during these conditions, and these may be taken. These substances may reach the lung circulation and may damage the epithelium and endothelium. This may be sepsis anywhere. Patient may have UTI, patient may have biliary tract infection, patient may have urinary tract infection, severe infection may cause this type of change. And necrotic tissue, especially bowel, sometimes there may be necrosis of the bowel due to obstruction, or usually in case of vascular abnormality, there may be necrosis, ischemia of the bowel segment, and once there is necrosis, there may be release of different enzymes present in the cells, and these may be the culprit for damaging the lung. And multiple trauma may be there. Multiple trauma, pancreatitis is another important cause. Pancreatitis, when there is severe acute pancreatitis, especially hemorrhagic one, then condition is very, very severe. Patient may also have ARDS. Cardiopulmonary bypass surgery, during surgery. Severe burn may be there. Patient may have severe burn, and during burn there may be infection. Burn may be accompanied by infection, and damage to the body cells may also release different type of enzymes and substances. These may also become toxic to the body, to the lung, to the epithelium, to the endothelium of the lung, and patient may develop ARDS. And drugs, for example, heroin, barbiturates, thiazides, diuretics, these may also cause ARDS. And major transfusion reaction, sometimes when incompatible blood is transfused, then patient may develop severe fever, and blood transfusion reaction may follow, and this may also lead to ARDS, pulmonary edema due to ARDS, pulmonary edema due to ARDS. This is due to damage to the epithelium, damage to the endothelium. So another may be anaphylaxis. Anaphylaxis may be due to some drugs, usually wasp, bee, scorpion bite, skin venom, envenomation, sometimes may cause damage to the lung. This especially snake bite, maybe due to cobra, maybe due to crate. This condition, these toxins, damage to the tissue, may release large amount of these toxic substances, which may induce inflammatory reaction. And as part of inflammatory reaction, there is damage. More and more cells are activated, more and more cytokines and inflammatory mediators are released, and there will be more and more severe form of damage to the lung, or damage to the alveoli and its capillaries. Okay, fat embolism may be there, or carcinomatosis. Sometimes there may be massive infiltration of cancers anywhere from the body to the lung. This may also damage the lung, but not very common. Sometimes, especially in lymphoma, it's sometimes lung cancer itself, or any tumor or any cancer arising from other part of the body may also cause this damage to the lung. And obstetric crisis, for example, amniotic fluid embolism, eclampsia can also cause. Another is DIC, disseminated intravascular coagulation may also cause. So there is Berlin definition of ARDS. You remember, in case of ARDS, there should be some initiating factors. There should be some initiating factor. In most of the cases, initiating factor can be identified. Usually onset within 1 week of known clinical insult or new or worsening respiratory symptoms. Usually at least within 1 week of, there may be some conditions which may initiate this inflammatory process, maybe infection or the trauma or whatever may be, within 1 week, within 1 week of known clinical insult. Then usually in most of the cases, initiating underlying condition can be identified. And bilateral opacities on chest X-ray, which sometimes may mimic opacity due to cardiogenic pulmonary edema or hydrostatic edema, not fully explained by effusion, lower or lung collapse. There may be opacity, this due to this ARDS and accumulation of fluid in the alveoli, and there is no evidence of, there should be no evidence of left ventricular failure, and there should be no evidence of lung collapse, no evidence of pleural fluid, and so on. If you are able to rule out cardiogenic pulmonary edema or left ventricular failure, if you are able to rule out lung collapse or atelectasis or pneumonias and pleural effusions, and patient is hypoxic, patient is severely critically ill, in such conditions, you must raise the suspicion of ARDS and measure AVG. AVG may reveal PaO2 by FiO2 ratio is decreased. Depending on this grading, mild ARDS is defined as PaO2 by FiO2 ratio between 200 and 300 mmHg. AVG must be done. If AVG reveal PaO2, FiO2 means fractional inhalation of oxygen, fraction of inhaled oxygen, FiO2, fraction of inhaled oxygen. This patient may require high fraction of oxygen inhalation. So PaO2 by FiO2 ratio, fraction of inhaled oxygen. PaO2 FiO2 ratio between 200 and 300 mmHg is mild. PaO2 by FiO2 ratio between 100 and 200 is moderate one, and severe one, PaO2 FiO2 ratio is less than 100. You remember, severe type of hypoxia. This type of hypoxia is difficult to correct by only oxygen by nasal cannula or mouth face mask. Difficult. You cannot be corrected. Most of the patients require this intubation and mechanical ventilation. Even non-invasive ventilation doesn't work. Even non-invasive ventilator does not work. You can try in the early phase. If patient is not maintaining proper oxygenation, if oxygen is persistently less than 60 mmHg, then patient must be ventilated and patient must be mechanically ventilated. Criteria are these. You must remember. You can find in your book also. And treatment, you remember treatment of ARDS, this non-cardiogenic pulmonary edema. Treatment of initiating illness is important. Find out some infection or some pancreatitis or some kind of pancreatitis or some kind of tissue necrosis anywhere. There may be focus outside the lung. Focus may be inside the lung itself, causes maybe pneumonia or some toxic inhalation or aspiration. In most of the cases, causes may not be in the lung, maybe in the urinogenital tract, maybe in the biliary tract, maybe in the gut, maybe in the anywhere, or some kind of trauma. There are variety of causes which may lead to ARDS. You must know. If patient is presenting with urinary tract infection, few days ago, there may be pyelonephritis, and suddenly patient become dyspneic, respiratory rate become very, very high. And when you take SpO2, this pulse oximeter oxygen saturation by pulse oximeter, maybe 80, 80, 81, 80, or maybe less than that, maybe less than 90. And you must always raise suspicion of ongoing ARDS. This UTI or urinary tract infection or anywhere, this might have involved the lung, which may cause ARDS. Septic shock, as part of septic shock, you might have heard septic shock, septicemia as part of infection may cause septic shock, septicemia, or acute inflammatory response. These may all damage the lung and may lead to ARDS. Once ARDS is established, patient may develop severe hypoxia, which is very difficult to correct. You must know. Continuous positive airway pressure, CPAP can be tried. CPAP can be tried, but in most of the cases, CPAP does not work. CPAP means this continuous positive airway pressure. This is not performed by intubation. There is a face mask or nasal mask through which high pressure is applied with oxygen, and sometimes it may work in milder cases, and hypoxia not caused by ARDS may be useful. For example, patient with COPD, patient with left ventricular failure. This maneuver, this non-invasive ventilator CPAP, there is another BiPAP, bi-level positive airway pressure is also available. This can be useful in case of severe hypoxia due to respiratory failure, or hypoxia due to left ventricular failure, or sometimes patient with neuromuscular junction disease, or neuromuscular junction disease may cause weakness of muscles and may lead to hypoventilation. In such conditions, this BiPAP, CPAP may be useful. But in milder cases of ARDS, you can try in the early stage. If patient is not responding, and intubation is required. In most of the cases, intubation is required. Endothelial intubation and mechanical ventilation with PEEP, PEEP. PEEP is positive end expiratory pressure of usually 5 to 15 cm/2 is applied. This is because high pressure is required, because I already mentioned alveoli are filled with proteinous substances and fluid. Alveoli are collapsed. There is loss of secretion of surfactant by pneumocyte 2, and there is no opening up of alveoli during inspiration. So you have to apply larger pressure to open up the alveoli. So patient require PEEP. This is the underlying mechanism of requiring PEEP in patient with ARDS. Alveoli are damaged, alveoli are collapsed, filled with proteinous substance. At the same time, there is no secretion of surfactant. Surfactant is useful to maintain integrity of the alveoli. You might have studied in physiology. Surfactant help maintain integrity of the alveoli. It prevents from collapsing in normal condition. When alveoli are not secreting these surfactant, then alveoli easily collapse. You remember atelectasis of these alveoli in ARDS. So larger pressure or higher pressure, higher PEEP positive and expiratory pressure is required to open up the alveoli. But it is also difficult. Sometimes nowadays there is prone ventilation is also applied to improve oxygenation. Prone, usually patient is supine in most of the cases. Nowadays some studies have revealed ventilation in prone position may also improve oxygenation in ARDS. Okay, I discussed about this ARDS. This is non-cardiogenic pulmonary edema. I am going to discuss the main part of this acute pulmonary edema is acute cardiogenic pulmonary edema. You remember, once somebody asks you pulmonary edema, whether it is due to cardiogenic pulmonary edema or non-cardiogenic edema as part of ARDS, your mind must think of this. Every time when somebody talk about pulmonary edema, there are two types, whether it is part of ARDS or part of left ventricular failure. These are important. So sometimes examination may reveal causes and treatment of acute pulmonary edema. I think this term, saying this is not very Nice. Better to a very keen examiner must ask what are the causes of cardiogenic pulmonary edema? Must be asked in this way. Or how do you manage a case with acute cardiogenic pulmonary edema? Or somebody says describe management of acute pulmonary edema. If it is asked in this way, then it is vague. I think it is vague. It is better to be clear cut. Anyway, if otherwise not mentioned, you try to mention this non-cardiogenic pulmonary edema, that is left ventricular failure. If it is not specified in examination, you better explain the cardiogenic pulmonary edema due to left ventricular failure. But you can, very keen student can also raise the possibility of this cardiogenic, non-cardiogenic pulmonary edema. The correct question is cardiogenic pulmonary edema, I think. Causes acute cardiogenic pulmonary edema, acute left ventricular failure. There are two types of heart failure. One is chronic heart failure, chronic left ventricular failure. Another is acute left ventricular failure. Chronic left ventricular failure may arise slowly over months or years and can be easily treated. Sometimes this acute pulmonary edema may arise out of the blue. Sometimes may arise out of the blue. Suddenly, patient may be all right till yesterday or a few days ago, and patient suddenly develop left ventricular failure. Patient become dyspneic and may come to you or may come to the emergency due to pulmonary edema and severely due to severe hypoxia and shortness of breath. Causes may be, you remember, acute, chronic, different. Chronic cause may be different. There may be slow progression of heart disease. For example, there are mainly 4 diseases. There are 3-4 diseases. One is hypertensive heart disease, which is chronic, slowly build up. There is cardiomyopathy. Cardiomyopathy, 3 types of cardiomyopathy: dilated cardiomyopathy, restricted cardiomyopathy, and hypertrophic cardiomyopathy. And the third one, the important one, is coronary artery disease. This may also cause left ventricular failure or ventricular failure. Coronary artery disease. And fourth one is valvular heart disease. These are the main heart diseases that may cause chronic heart failure. In these conditions, there is slowly building up of pathophysiology. These conditions may first of all induce compensatory mechanism. Compensatory mechanism may be activated through neurohormonal activation, ventricular hypertrophy, and ventricular dilatation. These neurohormonal mechanism is important. You must know these compensatory mechanism may be activated in case of chronic left ventricular failure. There are diseases, chronic diseases, which may cause slow impairment of the ventricular function. These 4 types of disease, valvular heart disease, cardiomyopathies, and coronary artery disease, hypertensive heart disease. These are main, and these disease may build up slowly, and they may damage the left ventricle slowly or heart slowly. During this time, there is time for the compensatory mechanism to take over, and there may be activation of compensatory mechanism. This compensatory mechanism try to maintain normal homeostasis or normal cardiac function. But over and over activation of compensatory mechanism is deleterious, not beneficial to the body. More and more activation, more and more sodium and water retention, more and more sympathetic stimulation, more and more hypertrophy of the ventricle, more and more dilatation of the ventricles. These are all not friendly to the cardiac function. Early stage, these compensatory mechanism try to maintain normal homeostasis. More and more activation of this compensatory mechanism is deleterious. You remember this. So there is plenty of time for chronic heart failure to be corrected or to be compensated. But in case of acute one, there is no compensatory mechanism. Heart is not prepared for this. Body is not prepared for this. Kidney is not prepared for this. Lung is not prepared for this. Especially heart is not prepared for this. In case of acute, only chronic case may induce compensation, but acute there is no compensation. Causes of acute left ventricular failure there are 2 types. Maybe one is acute left ventricular failure. This heart disease may develop suddenly out of the blue in so-called healthy heart, previously so-called healthy heart, Another may be acute on chronic left ventricular failure. Left ventricular failure was already established in the past. There may be chronic left ventricular failure. Certain precipitating factor may act on inappropriately addition or decrease of some treatment, or some conditions that may cause overload to the heart, or some drugs may impair the function of the heart, or there may be some precipitating factors like infections. These may all cause further damage or further overload to the heart, may put further overload to the heart, and acute on chronic left ventricular failure may arise. Remember, two causes. One is acute left ventricular failure. You must know there is myocardial infarction. Patient was all right. Myocardial infarction may develop suddenly without any premonitory symptoms. Patient was all right yesterday, and this morning patient was on morning walk and suddenly experienced central chest pain, and patient suddenly collapsed. Patient becomes dyspneic, and this may be myocardial infarction, damaging or causing necrosis of large part of the heart, and there is sudden increase in pulmonary vein pressure and pulmonary edema. Suddenly there may be elevation of hydrostatic pressure. Patient may become very dyspneic. You remember this. So previously healthy heart, there are two conditions: acute left ventricular failure and acute on chronic left ventricular failure. Previously healthy heart, myocardial ischemia or infarction, severe myocardial infarction or severe ischemia, maybe non-ST segment elevation MI, maybe ST segment elevation MI, or non-QAF MI, unstable angina. Severe heart failure is there due to this ischemia or infarction in a previously healthy heart, because this ischemic attack may be the first presentation. Patient may be all right till yesterday or till few days ago. This may also happen in completely so-called healthy heart. Not patient did not undergo any investigation in the past, but no symptoms, no premonitory symptoms, and patient suddenly develop this myocardial infarction. Another is myocarditis, viral myocarditis. There are so many, especially in adolescents. This viral myocarditis is very common, and viral myocarditis may be due to Coxsackie virus, maybe EB virus. There may be so many viruses which may cause this myocarditis. And you remember other conditions, this septic, as part of septic shock, toxic myocarditis can also cause this left ventricular failure. Patient along with ARDS at the same time may have some problem of the myocardium. This is because of toxicity may also impair the function of the myocardium, which may impair the contractility of the myocardium, and heart may fail. Okay, this myocarditis may be there, or some toxin, some cancer drugs can also damage the myocardium, heart, which may also cause left ventricular failure, especially myocarditis of viral origin. And as part of septic shock or septicemia, this toxin may also damage the myocardium, and patient may develop acute left ventricular failure in previously healthy heart. You remember this. Factor precipitating or aggravating left ventricular failure with pre-existing heart failure. I already mentioned there is pre-existing heart disease, chronic heart failure is there. Patient was on medication. Patient was working with medication, and suddenly some precipitating factors may act on heart, and this previously compensated condition may become uncompensated. Okay, previously compensated mechanism, patient was all right, patient was on compensation, patient was on medication, patient was all right until certain precipitating factors acted on heart, and this precipitating factor may cause compensated heart failure into uncompensated one, which may cause acute left ventricular failure, which may cause acute on chronic left ventricular failure and acute pulmonary edema. Factors precipitating the left ventricular failure in pre-existing heart are intercurrent infection, especially chest infection is important. Chest infection, pneumonia, any type of chest infection or infection anywhere as part of septicemia can impair the function of the already compromised lung. Myocardial ischemia, patient was already diagnosed to have left ventricular failure, maybe due to chronic left ventricular failure, maybe due to coronary artery disease. There may be frequent episode of ischemic attack, and during this ischemic attack, patient may experience as part of shortness of breath. Sometimes this shortness of breath may form a part of angina also. You might have heard or might have read somewhere. This shortness of breath may be a part of angina equivalent. Okay. And third one, some arrhythmia. Heart is compromised, already compensated with medication. Patient is okay with medication. Chronic heart failure is there. Suddenly there may be some kind of arrhythmia arises. Maybe most common is atrial fibrillation, ventricular arrhythmia, any kind of supraventricular arrhythmias, and this may impair the systolic and diastolic function, impair the diastolic feeling, and further deterioration of the lung heart function, which arrhythmia is another cause. Inappropriate reduction of therapies. Sometimes patient was on ACE inhibitor, diuretics, or some other medications for chronic heart failure. Sometimes there may be patient, sometimes iatrogenically or patients on their own may stop taking medication as advised. And once there is reduction or stopping of medication, sudden aggravation of previously existed left ventricular failure may follow, and this may constitute the acute on chronic left ventricular failure. Administration of drugs with negative inotropic properties. You might have heard, patient is on left ventricular failure, patient was getting medication for left ventricular failure, sometimes inappropriately addition of some medications with inotropic effect. For example, verapamil, deltaazine, they have negative inotropic effect. But beta blocker, you remember, nowadays beta blocker must be given in case of chronic left ventricular failure. There is mechanism, later you will be taught or you will know. Nowadays, beta blocker must be a part of treatment of chronic left ventricular failure, but it is not given in acute left ventricular failure. If you don't give beta blocker in chronic left ventricular failure, your treatment regimen is not complete. You must prescribe beta blocker in chronic left ventricular failure if there are no contraindication for the use of beta blocker. Okay. Sometimes some drugs with negative inotropic effect may also impair the function of the heart, and patient may develop acute and chronic left ventricular failure. Fluid retaining property. Some drugs with fluid retaining property may be there. For example, NSAIDs, corticosteroids may cause or excessive salt intake. Sometimes patient may take excessive salt. Some patients some may have a habit of taking large amount of salty meals. So somebody's left ventricular failure may not be controlled properly, still having this pedal edema and shortness of breath. If you take proper history, sometimes they may be taking large amount of salt, maybe more than 3-4 gram per day. Usually less than 2 gram, 2.5 gram per day is enough for this patient with left ventricular failure. Any healthy eating, this less than 3 gram of salt per day is enough. So some may be taking 3, 5, 4, 6 gram of salt every day. This may be cause this water retention. Sodium may cause water retention. And condition associated with increased metabolic demand. Sometimes patient was all right, chronic left ventricular failure on medication, well compensated, no problem. Suddenly patient become pregnant, and hemodynamics may be changed. There may be fluid overload during pregnancy, and there may be increased metabolism in pregnancy. Similarly, in case of thyrotoxicosis, there is increased metabolism, increased load of increased burden to the heart in case of thyrotoxicosis. Similarly, in anemia, these conditions may cause hyperdynamic left ventricular failure. Due to increased metabolic demand, left ventricle or heart has to pump quickly and hard. So there may be increased heart rate, increased function of the heart. This may cause fatigue. if you perform very work, if you perform or complete some work vigorously and briskly, then you will get fatigued easily. Similar mechanism. In case of hyperdynamic circulation, left ventricle or heart has to work hard with prolonged these hyperdynamic conditions may ultimately cause damage to the myocardium, damage to the heart, and ultimately it fails. Similarly, cardiac output in the early stage of hyperdynamic circulation, cardiac output may increase, blood pressure may increase, but it cannot be sustained for long duration. Over and over activation, over and over work, overload, work of excessive work may ultimately cause fatigue. Similarly, you get fatigued after doing some task vigorously. Similar mechanism. And IV fluid overload. Sometimes, especially in post-operative patient with chronic left ventricular failure underwent surgery. During surgery, patient was infused large amount of saline or any glucose, whatever, dextrose, whatever may be. This may cause this overload, volume overload, and may cause sudden left ventricular deterioration, function deterioration, and pulmonary edema. And patient may have renal failure. Sometimes renal failure is there. Patient is not passing urine, There is accumulation of fluid in the circulation. This condition is called overload. Maybe iatrogenic overload because of infusion or intake of large amount of fluid, or there may be volume overload due to renal failure. Sometimes there may be acute renal failure. Kidney may not be excreting any urine, or urine output may be very less. This may cause acute renal shutdown, and these further add to the left ventricular volume overload and left ventricular fail. And similar nephrotic syndrome. These are the conditions you must remember, conditions that may cause acute left ventricular failure, or condition with chronic disease that may exacerbate the left ventricular failure, which we call acute on chronic left ventricular failure. Pathophysiology is, I already mentioned in most of the cases, increase in left ventricular diastolic pressure because there is remaining volume in the lung, remaining volume in the left ventricle at the end of systole, because left ventricle is not pumping properly. Large amount of volume is still remaining there. This may lead to increased diastolic pressure. So for this, there should be increased filling pressure from the or pressure gradient from LA to LV is increased. This is due to increased diastolic pressure. This increase in diastolic pressure may lead to increased pressure in left atrium. This pressure is backwardly reflected. And pulmonary vein, pulmonary capillaries. There is increase in hydrostatic pressure in pulmonary vein, pulmonary capillaries. When this hydrostatic pressure exceeds oncotic pressure, water molecules leaks into the interstitium and alveoli. Hydrostatic pressure of the pulmonary capillaries exceeds the oncotic pressure. Usually oncotic pressure is about 25 to 30 mmHg. In normal condition, oncotic pressure is 25 to 30 mmHg. When this value is exceeded by hydrostatic pressure, then fluid moves from the capillary into the alveoli. There is flooding of alveoli. There are large amount of fluid. There is fluid in the alveoli. There is no space for gas exchange, no space for gas or air, and definitely patient will be dyspneic and hypoxic. Alveolar flooding and interstitial edema, which may stimulate respiration through a series of autonomic reflex. There is fluid in the alveoli, there is fluid in the interstitium. You might have heard there is J receptor, J receptor present in the interstitium, and these J receptor may get stimulated, and through reflex, this autonomic reflex, respiratory rate, which may send message to the respiratory center in the brain, and respiratory rate may increase because there is hypoxia, which at the same time this hypoxia may also induce respiration, increase in respiration through reflex. At the same time, there are J receptor present in the alveoli, wall of the alveoli. These get stimulated, and these are, once these stimulated, then autonomic reflex may cause this increased respiratory rate and patient become dyspneic. So patient will have rapid and shallow respiration. This is because of reflex increase in respiratory rate. Hypoxia is there. This is sensed by autonomic nervous system, this vagal nerve, and same messages are sent to the central nervous system, this into the respiratory center, and there may be increased drive to the respiratory muscle, and there will be, but this respiration is rapid but not deep, shallow breathing is there. Vairaj, teacher. Any congestion of the bronchial wall, mucosa because of edema. This may also reduce the caliber of the airway. Once there is reduction of caliber of the airway, there will be wheezing. This reduction in caliber, smaller airways, caliber of smaller airways will be reduced because of edema of the airway wall, mucosa, or any whole airway wall may be edematous. This may cause narrowing of the airway, and this may also impair gas exchange or ventilation. Usually there is obstruction, there is increased resistance of air lower airway. So this may all cause gas exchange. Maybe reflex, autonomic reflex may cause airway narrowing through activation of Z receptor. At the same time, there is edema of the airway wall, which may narrow the caliber of the airways, and these may all cause wheezing of the lung. On auscultation, you may appreciate wheezing all over the lung, sometimes mimicking COPD and bronchial asthma. So this condition, this wheezing caused by left ventricular failure and pulmonary edema is called cardiac condition. Sometimes it is difficult to distinguish it from bronchial asthma. Bronchial asthma is another thing. This is due to lung disease, and cardiac asthma is due to cardiogenic pulmonary edema. Patient may have wheezing all over the chest on auscultation. This condition is called cardiogenic cardiac asthma. This is due to acute pulmonary edema due to left ventricular failure. Remember, okay. Usually, especially on supine position, patient become dyspneic. Acute case, patient find very difficult to lie flat. Patient has to get up, or patient has to sit upright or standing. By doing this, pulmonary edema is reduced, preload is reduced because of force of gravity. This force of gravity help retain fluid in the lower part of the body, and blood returning to the cardiac chamber will reduce, and this may lead to decrease in severity of pulmonary edema. Okay. Hyponatremia, natremic state sometimes can cause this type of, for example, in nephrotic syndrome, there is decreased oncotic pressure. This decreased oncotic pressure can also theoretically also cause this pulmonary edema, but this condition is not very common. Many nephrotic syndrome, diabetes may be there, maybe SLE may be there, membranous nephropathy. There are so many nephrotic syndromes which is characterized by decreased oncotic pressure. But this decreased oncotic pressure usually, theoretically, there should be pulmonary edema when there is decreased oncotic pressure in case of these conditions. But this acute cardiogenic pulmonary edema due to these oncotic conditions, due to nephrotic syndrome is not very commonly seen. But theoretically, it may happen. It may happen. You should remember. Sometimes it may happen. Sometimes nephrotic syndrome is there. At the same time, other factor may be present at the same time, and both may contribute to the development of acute pulmonary edema. Clinical manifestation is important. This is medical emergency. If not treated immediately and properly, patient will die. You remember, acute pulmonary edema is a medical emergency. If not identified and treated immediately, patient will die. Patient will die. You remember. Clinical manifestations are acute onset of severe dyspnea. Dyspnea is terrifying. Patient is apprehended. Patient is very, very panicked. Patient is panicked usually because there is no compensation. The shortness of breath may come out of the blue suddenly, and there is no compensation. and patient may become very, very severely dyspneic. Patient is terrifying, patient is panicked, and patient may have sense of dying. Patient may have dying sensation. Patient may have dying sensation. Sitting upright or standing may provide relief. When patient is very dyspneic on supine position, when patient sits upright or stands upright, then shortness of breath may be relieved. This is because of decrease in preload. On standing, there will be gravitational force acting on the lower part of the body. This causes blood, fluid, fluid to trap in the lower part of the body or retain in the lower part of the body. This force of gravitation causes accumulation of fluid in the lower part of the body, and blood returning to the ventricle or to the pulmonary circulation is reduced. Reducing this preload may relieve shortness of breath because there is increased fluid in the interstitium and patient is upright of the body. There will be more accumulation of fluid in the lower part, and blood returning to the left ventricle or blood returning to the pulmonary circulation is reduced, and patient's degree of shortness of breath may be relieved. You remember, you must understand this. And patient may be unable to speak in a sentence because this shortness of breath. There may be activation of sympathetic nervous system. Patient is agitated, patient is sweaty, and patient is pale. Patient is sweaty. The hands are cold and clammy. Hands are cold because there is less circulation. Clammy means there is sweaty, moist. Hands are moist because activation of sympathetic nervous system may cause increased sweat formation. This is through acetylcholine. You remember this. Sweat glands are supplied by sympathetic nervous system with acetylcholine as neurotransmitter. So these causes increased sweating. Circulation is poor, peripheral perfusion is poor, patient is pale. At the same time, pulse is rapid and thready, and hands, extremities are cold, at the same time clammy, they're moist. This is because of overactivation of sympathetic nervous system. But overactivation of sympathetic nervous system can increase the secretion, increase the sweat gland, increase the function of sweat glands, and patient hands may be moist. Patient may have perspiration. This is the mechanism. Somebody may ask you, what is the mechanism of perspiration? What is the mechanism of these moist and pale hands, cold extremities? Sweating is there, but limbs are or extremities are moist. Cyanosis is there because of decreased oxygenation, and rapid shallow respiration with recruitment of accessory muscles. Because patient is dyspneic and patient may be using maximum force to inhale and exhale, especially inhalation, and patient may be using accessory muscles of respiration. There may be sternocleidomastoid, scalene muscles, and respiratory muscles, these intercostal muscles, especially these trapezius, sternocleidomastoid, and these scalene muscles are the accessory muscles. These muscles may be acting, patient may be acting. At the same time, coughing and wheezing may be there. Sometimes wheeze may be heard from outside. Sputum may be profuse. You remember, sputum may be profuse, frothy, and blood streaked or pink colored. Pinkish colored sputum may be there. Frothy sputum. You remember, sputum is not mucoid, frothy. In case of COPD, sputum is mucoid, thick usually mucoid. In case of left ventricular failure, there is no increase in mucus secretion in case of left ventricular failure. Only in COPD, there is hypertrophy of goblet cell, hypertrophy of mucus secreting cells. So these hypertrophy may lead to increased viscid fluid secretion, that is mucus. So in case of COPD, large amount of sputum may be there, but it is thick and mucoid. In left ventricular failure, there is no overactivation of mucus gland. There is increased fluid component. There is increased fluid or increase water molecule in the alveoli and interstitium. So there is no mucoid. Frothy unasaksa, there is frothy sputum because of air bubble inside the sputum, but not mucoid. And because of increased hydrostatic pressure and dilatation of capillaries, red blood cell may escape into the alveoli, escape into the alveoli, and patient may have pink colored sputum, or sometimes frank hemoptysis may be there, sputum streaked with blood may be there. And have you heard about heart failure cell? Heart failure cell, have you heard about heart failure cell? You must have been taught in pathology. Heart failure cell. Do you know heart failure cell? Hello.
Yes, sir. Yes, sir.
What is heart failure cell?
Homocysteine in Latin macrophages are called heart failure
Yes,
cell.
yes, there are macrophages in the alveoli. These increase pressure in the capillaries may cause leakage of RBCs into the alveoli, and these RBCs may be engulfed by macrophages, and later on there may be these macrophages may have on microscopy this hematine or hemoglobin deranged hemoglobin may be there on may be found in microscope. This is heart failure cell. So patient may have hemoptysis. This left ventricular failure is also a cause of hemoptysis. But hemoptysis is usually not very massive. But in case of mitral stenosis, there may be massive hemorrhage, hemoptysis. In most of the cases, there may be streaking of blood and pink colored sputum may be there in case of left ventricular failure. You remember this. Okay. And extensive crackles and rhonchi in the chest. When you appreciate lung, by your stethoscope, you may appreciate crackles. Usually in early stage, there may be basal crackles, and with the increase in severity of left ventricular failure, level of these crackles may elevate, may sometimes covered whole lung field. This is the clinical manifestation of left ventricular failure. Investigation, cardiac, first of all, you should take history properly. Patient may have repeated attack of angina in the past, but patient's cardiac function may be normal. After repeated, patient might have previous history of repeated recurrent coronary artery disease manifestation by, yes, this angina pectoris. Even if angina pectoris, cardiac function may be normal, and sometimes severe anginal pain may follow, and sudden myocardial infarction may occur. So previous history is important. And most of the abnormalities can be detected by ECG, chest X-ray, echocardiography, and clinical examination. These are important. Clinical examination, proper history taking, clinical examination, and these findings can be substantiated by ECG finding, X-ray finding, and echo finding. So CXR PA view band, most important and easily available investigation is chest X-ray. Chest X-ray PA view is important. In acute left ventricular failure, there may be no enlargement of left ventricle usually because there is no compensation, no dilatation and hypertrophy of the left ventricle in case of acute left ventricular failure. So heart size may be normal. Sometimes you may say there is no enlargement of, there is no cardiomegaly, the left ventricular failure is less likely. Don't make conclusion like this, because in early stage in acute left ventricular failure there is no time for compensation. There may be no cardiomegaly, cardiac silhouette or cardiac shadow may be normal. So other features that may suggest underlying pulmonary edema may be pulmonary vascular redistribution. This is terminology, that is pulmonary vascular redistribution. On chest X-ray, you may find more vasculature in the lower field of the lung, But in case of left ventricular failure, there may be prominent pulmonary vein in the upper part of the lung. This is called redistribution of vessels in the lung field. In normal condition, pulmonary vessels are prominent in the lower part of the lower part of the lung fields. In acute pulmonary edema, there is increased pressure in the pulmonary vein, increased hydrostatic pressure in the pulmonary vein. So this may cause dilatation of pulmonary vein tributaries in the upper part of the lung. So upper part of the lung may be engorged or there may be prominent vessels seen in the upper part of the lung or lung field. This is called redistribution of blood vessel. You remember this. Abnormal distension of the upper lobe pulmonary vein. This is due to increased pulmonary vein hydrostatic pressure. In normal condition, only lower part have prominent vascular markings. In upper part of the lung, vascular markings are not prominent. So in case of left ventricular failure, when you find upper lobe is engorged or increased vasculature of the vessel or increased vasculature, then this may be due to left ventricular failure. And blurriness of vascular outlines. This is because of dilatation and exudation, interstitial edema, blurring of the vascular outline, not distinct, not very sharp. In normal condition, vessels outline is sharp and easily visible. In case of pulmonary acute cardiogenic pulmonary edema, vessels are blurry, not distinct. So blurriness of vascular outlines is there on chest X-ray. Increased interstitial markings may be there. Interstitial marking cannot be visible in normal lung field properly. You cannot identify interstitial markings. But in pulmonary edema, there may be increased interstitial markings because there is fluid in the interstitium. So marking may be increased. Butterfly pattern of distribution of alveolar edema. Usually this alveolar edema is more prominent in the hilar part of the lung, and butterfly pattern is usually there. This butterfly pattern is due to alveolar edema. At the same time, patient may have effusion also. Effusion, bilateral effusion may be there because of interstitial fluid and alveolar fluid. This interstitial fluid may also escape into the pleural space, and patient may have small amount of pleural fluid also. Heart size enlarged or normal. Usually, if there is some degree of previous heart disease, chronic heart disease, patient with chronic heart disease may have enlarged heart. But acute conditions causing left ventricular failure, usually normal heart. And another important finding that help distinguish from, sometimes you may be confused. Patient may have this acute shortness of breath, sudden onset. You may be confused whether it is due to left ventricular failure or ARDS, or it is due to cardiogenic pulmonary edema or non-cardiogenic pulmonary edema. Non-cardiogenic pulmonary edema is ARDS. So distinction is important. Treatment approach is totally different in these two conditions of pulmonary edema. You remember, in such condition, if available, not available in our setup, but you must know theoretically, this pulmonary capillary wedge pressure is useful. If sometimes, in most of the cases, echo, ECG, clinical manifestation can make a proper diagnosis in most of the cases, usually in 99% of the cases, more than 99%, but I think. But sometimes there may be difficult. And if such condition present, then you can measure the pulmonary capillary wedge pressure. This catheter is Swan-Ganz catheter, that is called, can be introduced into the pulmonary artery. You introduce this catheter as distal as possible so that it reflects the pulmonary capillary pressure. If you introduce this catheter as distal as possible so that it reflects the pressure of the pulmonary capillary. This pulmonary capillary pressure indirectly reflects the pressure of the left atrium. Remember. So this PCWP, pulmonary artery wedge pressure, is elevated in case of cardiogenic pulmonary edema. It is usually more than 25 mmHg. In normal condition, it is usually less than 15. Whereas in case of non-cardiogenic pulmonary edema in ARDS, this pressure is not elevated or sometimes even low. It is usually less than 15 mmHg. In cardiogenic pulmonary edema, this pressure, this PCWP, pulmonary capillary wedge pressure, is more than 25 mmHg or elevated. This indirectly reflects the condition of the left atrium. Okay, you remember this, you understand this? Do you understand this? Hello?
Yes, sir.
Okay.
Yes, sir.
Okay, let's talk about treatment. Treatment is important. You remember, I have made a mnemonic for memorizing the treatment approach. You remember LMNOP. LMNOP. L means Lasix, this furosemide. You must give furosemide, Lasix, to reduce preload. At the same time, it also causes venodilation. This venodilation can also decrease preload. Before initiating diuresis, it can also cause venodilation. Once venodilation, capacitance vessels may be dilated and it may cause decreased preload, and it may also help decrease the severity of pulmonary edema. M means morphine. Patient with acute pulmonary edema must be given, you must give morphine, so that it can also decrease the anxiety. At the same time, it also increase the capacity of vein, capacitance vessels may be dilated, and it may also decrease the preload. Okay. N means nitroglycerin, especially patient with hypertension. If these patients develop acute left ventricular failure, this nitroglycerin is very useful. It can both decrease preload and afterload by vasodilatation, and at the same time, this nitroglycerin can decrease the blood pressure. O means oxygen. Give oxygen, high flow oxygen, high concentration oxygen. Don't afraid of giving high flow of oxygen. In COPD patient, you should not give high flow oxygen, but in left ventricular failure, you can give. P means propped up position. Positioning should be proper. Propped up positioning may decrease the preload, because propping up the patient can cause accumulation of fluid in the lower part of the body, in the limbs, due to increase in gravitational force, and blood returning to the cardiac chamber will decrease, and this may decrease the severity of interstitial edema by decreasing preload. So LMNOP approach is important, and let's talk one by one. One is this positioning, sitting up position or propped up position. Put patient on Fowler way. This may cause elevation of the upper part of the body, and this force of gravity will act on the lower part, and it helps accumulate fluid in the lower part, or blood in the lower part. So blood returning to the lung is reduced, and this may cause decreased pulmonary edema. Okay, and sometimes you can also ask patient to dangle the legs on the side of the bed. Dangling of the legs on the side of the bed. Dangling of the legs on the side of the bed, so that force of gravity will act on the lower part. If patient is able to move a little bit, then you ask patient to dangle you ask patient dangling of the legs, so that it may also help reduce pulmonary edema. So this also facilitates respiration. This venous return, it facilitates respiration and venous return. O2 therapy, oxygen therapy, high flow, high concentration of oxygen is there, should be there. You should supply with high flow, high concentration oxygen. Maintain arterial PO2 more than 60 mmHg. Our target must be to maintain arterial PO2 more than 60 mmHg. Non-invasive positive pressure ventilation may be tried if nasal cannula or face mask fail to maintain oxygen saturation and this oxygen tension. Then you can try with non-invasive positive pressure ventilation. CAP, CPAP is there, CPAP, CPAP, continuous positive airway pressure is there. there is no need to intubation, no need to intubate. There is face mask or nasal mask. If patient is cooperative, you can give nasal mask. If patient is not cooperative, you can try with face mask. Or if patient is having altered sensorium, then trying with this non-invasive ventilator is not good. If patient is hypoxic, not corrected with nasal cannula and face mask, then if patient is not cooperating with this non-invasive ventilator, sometimes patient may also require intubation and mechanical ventilation. But in most of the cases, this nasal cannula or by face mask or non-invasive ventilation giving oxygen may be beneficial. In most of the cases, we can solve the problem with these measures. Intubation is required when patient is incooperative and patient is severely patient is having severe respiratory failure. Morphine, how does morphine work? Highly effective in pulmonary edema. Initiate dose 2 to 8 mg IV or SC can be given in milder cases. Subcutaneous can be given. IV can be given to, you can give 4 mg IV push, or in milder cases you can give subcutaneously. Can be repeated after 2 to 4 hours. Increase venous capacitance. It also increases the venous capacitance, dilate the capacitance veins, lowering left atrial pressure by decreasing preload. Left atrial pressure may be decreased by decreasing preload. And relieves anxiety at the same time. It has got anxiolytic action as well. Should be avoided in opioid-induced or neurogenic pulmonary edema. You should not use these. Sometimes opioid overdose or tranquilizer overdose. It may also induce ARDS, ARDS, pulmonary edema. Sometimes heart failure may also be there. Both conditions may arise with overdose of this opioid. Acute pulmonary edema may be there, both due to cardiogenic or non-cardiogenic cause. So in such condition, opioid must be avoided because it depresses the respiratory center and it may reduce ventilatory drive and patient may develop carbon dioxide retention. So neurogenic pulmonary edema, sometimes there may be some trauma in the brain, sometimes there may be severe cerebrovascular accident. In such condition, patient may also develop ARDS. So if such condition is causing ARDS, don't give morphine. So condition may be further compounded. Loop diuretics, usually furosemide can be given. Furosemide, there are so many drugs. Furosemide is very commonly used. Lasix, generic name is Lasix. So L comes from this Lasix, LMNOP. Furosemide 40 mg or higher can be given IV. Reduces preload. Reduces vasodilatation prior to onset of diuresis. It causes vasodilatation. So many people don't know the mechanism of furosemide. Many will immediately respond as there is increased urination or diuresis, and it reduces the preload. Before this diuresis, Furosix or furosemide causes vasodilatation. So patient becomes immediately less dyspneic, or patient become shortness of breath. Patient shortness of breath is relieved immediately after IV push of furosemide. This is due to vasodilatation and reducing the preload. Diuresis takes time, takes 10, 15, 20, 30 minutes to be effective. So before diuresis, there may be vasodilatation, reducing preload, and this IV furosemide is immediately effective. You must know the mechanism. Nitrates, these nitroglycerins can be given. There may be glycerin trinitrate can be given. This may also accelerate clinical improvement. It also reduces BP, blood pressure, if patient is hypertensive, and at the same time it reducing BP, reducing afterload and preload. There will be less burden to the left ventricle. If there is decrease in afterload, less burden to the left ventricle, and ejection or stroke volume may increase, and this may leads to resolution of increase in end diastolic pressure in the left ventricle, and patient may be improved. Particularly valuable in patient with accompanying hypertension. This also reduces the dyspnea rapidly. IV glycerin nitrate can be given. Buccal glyceride trinitrate can also be given in 2 to 5 mg. Sublingual tablet can also be given in milder cases, but in most of the cases, IV is recommended infusion, and the dose can be titrated up to the optimum response. These are the main treatment. LM and OB I already mentioned. There are other type also. In case of left ventricular failure, there is increase in brain natriuretic peptide. Okay, you have heard brain natriuretic peptide. This brain natriuretic peptide can cause diuresis. At the same time, it also reduces the blood pressure. There is artificially synthesized natriuretic peptide by DNA recombinant technology. This molecule has been synthesized, and this molecule is called nesiritide, Nesiritide. This nesiritide can be used in refractory cases. If other measure fails, this can be used, but effectiveness of other medication is better than this nesiritide. IV infusion improves dyspnea more rapidly than IV nitroglycerin, but it may precipitate hypotension. So you must be careful. This is expensive, not easily available in our country also. And if other measures fail, then you can try with. But in most of the cases, with other measures we already discussed, are effective. And sometimes positive inotropes can be given, but these don't improve the mortality. Sometimes it may exert some short-term relief and improvement, but with the use of these positive inotropes, mortality benefit is not seen. So in case of this condition, we can give dovitamin. Dovitamin is beta-1 agonist, which may increase the contractility of the myocardium and increase cardiac output. May be effective in short period of time, but use of this drug usually don't improve the mortality. At the same time, phosphodiesterase inhibitor is there, not very commonly used. This is called milrinone, but these drugs are not very commonly used. They are not used. Sometimes they may be used when all measures fail. So solution of no solutions as part of solution of no solutions can be used. But you remember this LM and OP, these two types of cardiogenic pulmonary edema, non-cardiogenic pulmonary edema and cardiogenic pulmonary edema. Cardiogenic pulmonary edema is important, causes you must know. Non-cardiogenic pulmonary edema is due to ARDS. There are different insult, indirect or direct insult, lung disease itself, or non-pulmonary disease arising from the other part of the body system, may all act on the lung circulation or lung or alveoli and endothelium, damage the lung through inflammatory process. There is cytokines, inflammatory process, cytokines, inflammatory mediators, which may damage the endothelium, damage the epithelium, causing leakage of fluid and protein into the alveoli. At the same time, there is impairment of function of pneumocyte cyst. Pneumocytes ceases to produce surfactant, and large number of alveoli go into collapse, and there will be incorrectable hypoxemia. This condition is treated mainly with mechanical ventilator. Okay, this was for today. Do you have any questions? Any any place difficult to understand? Hello? Do you have any question, any of you? No. Okay. This much for today. No question. No question. Abhishek Sharma, no question.